Good day, everyone. Today I am going to talk about obstructive sleep apnea, the problematic upper airway. I am Arik Paolo Delacruz. I am an assistant professor too at the College of Medicine at the West Visayas State University. So, for my references, the main reference I have for this talk is from the Philippine Clinical Practice Guidelines on the Diagnosis and Management of Obstructive Sleep Apnea in Adults. This was a project of the Philippine Society of Sleep Medicine, Philippine College of Chest Physician Council on Sleep Medicine, and of the Philippine Academy of Sleep Surgeons. The guidelines was published April of 2016, and I also got some materials from Guyton and Hall textbook of medical physiology, and also from various journals. So what is sleep? Sleep is defined as an unconsciousness from which a person can be aroused by sensory or other stimuli. So a person goes unconscious but can be aroused. Okay, that's the definition of sleep, and this is in contrast to other states of unconsciousness that they cannot be aroused. So the purpose of sleep was said to restore the natural balance in our body, mainly on the neurotransmitters in the brain, and thus this will also affect the bodily functions. So sleep is a central way of restoration, and the body will follow suit. And this is according to Guyton. And according to the American Academy of Sleep Medicine, an average adult will need 7 or more recommended hours of sleep. Lesser than that, the adult will have already sleep deprivation. So let's talk now of the stages of sleep, as you will see in this graphic. So we have the NREM, or the non-rapid eye movement stage, and it is divided into 1, 2, or 3. And this NREM is a phase in our sleep which is deep, restful, and restorative. We go to our sleep entering NREM first. We start with stage 1, deeper into stage 2, and the deepest is stage 3, wherein it is considered to be the stage wherein it is really restful. Then after the stage 3 NREM, we will go into a phase called the REM sleep. And this is what is considered to be the unrestful sleep, wherein you are dreaming, and thus your brain waves are very similar to that of the waking stage. However, you don't have muscle tone. No? There is a loss of muscle tone, probably because it should avoid acting out your dreams. No? It should avoid your body acting out your dreams. So the cycle of NREM 1, 2, and 3, then REM, this cycle every 90 minutes. Okay, so here we're going to talk about the typical night sleep. Here, this is the time plotted when you're awake at 0 hour. Then it progresses during the night. When we are going to sleep, we go directly to the non-REM phase. Okay, then it will be followed by cycles of REM, then going back again to non-REM, then REM, non-REM, REM, non-REM, and so forth. So the first few minutes of our sleep is supposed to be a restful sleep. Then this is the non-restful sleep phase, restful sleep, non-restful sleep. So let's talk about sleep and the upper airway. So the upper airway provides the ventilation when we sleep. So this is the upper airway, and this is a cross-sectional of our head and also our neck. So when we breathe, it goes into the nose and the nasal cavity at the back of the throat, then goes into the larynx and goes into the trachea and into the lungs. So notice in our upper airway, we have segments which are encased either in bone or in cartilage. Like in the nose, it is encased with cartilage, and also the nasal cavity, it is encased in bone. So when air passes through them, it doesn't collapse the tissue because the cartilage or the bone provides a good rigid structure. Also here in the trachea, it is composed of cartilage, and also the larynx, it's composed of cartilage, this one. So when air passes through, it doesn't change much. However, there is what we call a collapsible segment in our upper airway, which doesn't have bony support or cartilaginous support. Can you guess where it is? It is somewhere here. So it is in the start of the soft palate and the back of the tongue, and somewhere just near the epiglottis and the back of the throat. So the nearest bone that supports this collapsible segment is the hard palate that supports the soft palate, the hyoid bone which supports the epiglottis, and the mandible which supports the tongue. Okay, so all of this supports the soft tissue, and it will pull them away from the collapsible segment. Now this segment is very important when we're talking about obstructive sleep apnea, as you will learn later. So when a person goes into sleep in a supine position, this collapsible segment in the upper airway might be problematic for some people because it might collapse and will block the airway. Okay, so this is the airway when we sleep in a supine position. When this collapsible segment collapses, air won't be able to get through and reach the lungs. Very important structures in the collapsible segment when we are sleeping in a supine position are the following: the soft palate, the uvula, and the tonsils, and also the genioglossus. So this is the genioglossus. This is the palatine tonsils. This is the soft palate and the uvula. So in the supine position, they might go down, no? They might relax and they might go down, and thus there will be an obstruction. Also contributing to this potential obstruction is the presence of adenoids. In adults, usually adenoids are already involuted, meaning it already shrunk. But in children, the presence of adenoid can actually add to the obstruction during sleep. The adenoids starts to shrink at the age of around 7. So that's why in adults we don't really expect it to be there. But in some, there is a persistence of hypertrophied adenoids. Okay, so all of these structures represent a narrowing in the airway during sleep. So what are the types of respiration during sleep? We have the normal breathing, we have the snoring, and we have a sleep disordered breathing. So of course, we wanted to be in the normal breathing. Some may have snoring, but they're okay, it's just sound. But in some people, they have a disorder on their breathing during sleep, plus the fact that they can be snoring. So let's talk about snoring first. So snoring is the vibration of soft tissue of the upper airway during sleep. When air passes through, especially in the soft tissue, especially in the collapsible segment, air tends to vibrate them. And when they vibrate and when the soft tissue vibrates, there will be a sound. It's just like having a paper and you blow it and it will flutter. You will create a sound. So usually in the upper airway, it is produced by the soft palate or the uvula. Snoring can also be a symptom due to a narrowing of the upper airway. So I always tell this to my patients that it's like a whistle. You blow something to a whistle. The whistle has a small diameter. You don't see a whistle this big. So when you blow air to a very small caliber, you will produce a sound rather than this one, right? So that's how snoring works. In literature, around 26% of the population snores, and most likely those who have primary snoring are men, those who have increased weight, those who smoke, and those who partake alcohol more than the usual. Okay, so here we'll take a look at a video
The airway is completely open without any areas of obstruction or vibration. Here is what a vibrating uvula causing a snore looks like from the inside.
That is snoring. That's caused by the uvula vibration. Now let's talk about sleep disordered breathing. These are conditions of abnormal and difficult respiration during sleep. So first type of sleep disordered breathing is an obstructive sleep apnea. It is a disorder because of an upper airway obstruction. Second, we have the central sleep apnea, and this is a disorder of sleep wherein the brain doesn't send the signal to the body to breathe. That's why it's a disorder of breathing during sleep from the brain. So typical examples of this one are those who are overdosed with narcotics. Okay, they tend to hypoventilate. And we also have an entity called the sleep-related hypoventilation, and this is usually insufficient breathing due to other health problems like COPD or pulmonary hypertension, and these are not so common, unlike the obstructive sleep apnea, which is very, very common. Now, let's go to obstructive sleep apnea. So, obstructive sleep apnea is a cessation or decrease of breathing during sleep from a partial or complete narrowing of the upper airways. So, these breathing disruptions will lead to awakenings, preventing restful sleep. And if you don't have restful sleep, in the morning you will have daytime fatigue, you have less energy, and you will be very, very sleepy. Obstructive sleep apnea has a triad of snoring, apneas or cessation of breathing. Apnea means cessation of breathing, and excessive daytime sleepiness. The three elements should be there to call it OSA. Because some people might have snoring but they have no apnea, so it's not OSA. Or some people may have apneas but they have no snoring and daytime sleepiness, so it's not obstructive sleep apnea. And some people might have daytime sleepiness but you don't really snore. Okay, so the three elements should be present. Okay, so let's talk about sleep interruptions and OSA. So let's go back again to the sleep cycle earlier. So when there is a cessation of breathing, it wakes you up to gasp air. So when you start sleeping, you go to stage 1. Then if there is obstruction in the collapsible segment, you begin to wake up to gasp for air. That's why you wake up. Then you go back again to sleeping, then you wake up again, and sleeping and wake up again. So in this vicious cycle, you cannot reach stage 3, which is the restful sleep. You'll be sleeping, yes, but you'll only be at stage 1. So you won't have a restful sleep. So many persons feel unrestful or lacks energy even though they sleep the required number of hours. So it's more of the quality of sleep rather than the number of hours that you sleep. Some people even they tell us that they sleep around 8 hours to 10 hours, but they wake up still they feel lack of energy or they feel fatigue. Probably the quality of their sleep is not good. And this is actually what happens with OSA. There will be a problem in your sleeping because of frequent awakenings because of disruption of breathing. Okay, so let's take a look at this video from Profilo Surgical. So this is the upper airway. Okay, it goes to the trachea and to the lungs. That's in an upright position. So we can see here the collapsible segment as discussed. Okay, that's the collapsible segment. And this is okay when you're upright and standing. Okay, the body will have airway. But when you are sleeping, in some people it might be problematic, especially if they have collapsing segment during sleep. So in obstructive sleep apnea, this collapses and there will be an obstruction in this area. Okay, there's an obstruction in this area, and thus you cannot breathe, and your brain will tell you to wake up so that you will be able to gasp for air. Then you go back to sleep again, temporarily, and the cycle will repeat over and over again. Okay, you wake up again and sleep again, wake up again and sleep again. So who are at risk for obstructive sleep apnea? Usually male, those who are old male, and those who are obese. So you have 3 times chances of having OSA if you are a male, and you have an increased risk for OSA if you reach the age of 60. So what are the typical OSA physical findings? First is an increased neck circumference. So those males with greater than 17 inches neck circumference usually will have a risk for OSA, and 16 inches for females. And those also of obese category on their BMI. So take note, we have different BMIs if you are an Asian or a Caucasian. Okay, we have different BMI categories. The next physical finding is a modified Malampati score of 3 or 4. Malampati scoring is obtained when you take a look at the patient and tell them to open their mouth and stick out their tongue. Class 1 is you can see all the structures, the hard palate, the soft palate, the uvula, and the pillars. And class 2, if you cannot see the pillar, you can only see the uvula, the soft palate, and the hard palate. And class 3, if you can only see the soft palate and the hard palate, not the uvula. And class 4, you only see the hard palate. So this means that it's either the tongue is big or the collapsible segment over here is very tight. If you have a class 3 or class 4, you have a high risk of having OSA. Next is a big tongue and a retrognathia. So if you have a big tongue like this one, you will have tendency to have obstruction compared to a smaller tongue. So how do we know that this is a big tongue? Because of the ridges of the tongue. It means that the tongue is already pushed into the arch of the teeth. That's why it has already ridges on itself. So the tongue is so big in the oral cavity that it is pushed and deformed. So this is a big tongue. Okay, so you can check your tongue if you have a big tongue. But those who have smooth tongue, usually it is an okay sized tongue. So a big tongue will collapse during sleep. It will pull down and it can have chances of snoring or even OSA, because the larger the mass of the tongue, the more chances that it will go back during sleep. And this is retrognathia, wherein there is a congenital very small chin of babies. Okay, why does this pose to have an OSA risk? It's because that the mandible, a small mandible or a mandible that is really receded, the tongue's position will also be altered. Okay, the tongue usually is pushed back because of the mandible being pushed back. And these patients will have a really poor airway, especially when they sleep. And we have big tonsils. So this is how we grade the tonsils. We have grade 0 and grade 4. So 0, there is 0 tonsils. You cannot find any tonsils there. And 4, it is already kissing. It is already in the midline and you cannot see any more at the back of the throat. Okay, in between are the 1, 2, and 3. So how do you know if 1, 2, or 3? So 1 usually it's just barely perceptible on the pillars, very small. And 2 and 3, it's just like less than 50% from this point to the uvula, less than 50%, and more than 50% it's grade 3. So if you have like grade 3 or 4, you have a higher chances that you have OSA. So this is again a real pictures of big tonsils. So grade 4 really big, grade 2 less than 50%. Grade 3, more than 50%. Grade 1, it's barely perceptible. And grade 0 if you don't see anything. Next is enlarged uvula. So this is enlarged uvula. Okay, so this can also collapse during sleep, and it can actually be an obstruction to our airway. Okay, so this is a case of abnormal uvula. Sometimes this will present only as snoring. And an overjet. What is an overjet? It is a condition wherein the arch of the maxilla is more anterior than the arch of the mandible. So if this is a normal occlusion, this is an overjet. It's an overjet. So it can be seen here that the maxilla is way in the front and the mandible is way at the back on the normal occlusion. It only means that if your mandible is a little bit receded on the back, it's just like retrognathia. It means that everything, the jaw is at the back, and therefore airway is also compromised because the tongue position will also alter. This one, you see, there is very small passageway if you have an overjet. So that's why also in OSA, dentists really play a role because of the occlusion. Sometimes they want the occlusion to be more forward so that the mandible also pushes forward. How does OSA affects the body? It affects waking hours performance because of daytime sleepiness and its effect on focus and attention. OSA is also associated with various health conditions like atrial fibrillations, congestive heart failure, stroke, hypertension, coronary heart disease, diabetes, and others such as sexual intimacy and sleep-deprived partners because of snoring. So let's talk about this further. Let's talk about waking hours performance. If you are really sleepy because of disrupted sleep and you cannot reach an restful sleep, you will have a poor performance on waking hours because of your excessive sleepiness. Also, your performance is not on the optimum because of fatigue, because you were not able to recover during a restful sleep, and you have problems in attention, memory, and executive functions. Also, your mood becomes very irritable, and you will have anxiety and mood swings during the day. All of this because essentially you will have sleep deprivation if you have obstructive sleep apnea. How about OSA and driving? So in the past decade, there was interest in OSA and drivers. They found out that drivers with OSA has 2.5 times more accident than those without OSA because these drivers are less attentive, they have slow reaction time, and their excessive sleepiness will affect their decision making. This is important, especially those who are bus drivers or commercial drivers, just like carrying a passenger or those carrying goods. No, they can actually get into accident and also affect the passengers that they carry. So in the Philippines, there was already a study done on OSA and drivers. Well, personally, I made a study, a preliminary study on this one, but a published study shows that 46% of long-distance bus drivers in the Philippines has OSA and daytime sleepiness. So imagine that you're riding a bus, like a very long trip, and your driver is sleepy. Probably you will have a higher risk of an accident. It's very important that our drivers should be screened for this OSA and daytime sleepiness, okay? Because it's very important and it is a public health issue. Okay, so I found a video in YouTube. Okay, so yeah, so this is okay, a truck driver, and he take a look. He falls asleep. Okay, it may be fine at first. Body will tend to compensate. Look, usually these are males. These are usually obese males. Look how it swerves. Take a look. He dozes off, then wakes up, then tries to compensate, then goes into an accident. Okay, thankfully he is on seatbelt and he is okay. So what more if that driver is carrying passengers? No, it will be really a disaster. OSA is also associated with a variety of health conditions, and this has been validated by a lot of studies. The most common OSA-associated health condition is the development of hypertension. Also, coronary artery disease, cardiac arrhythmias if you have OSA, and heart failure is worsened if you have OSA. Also, the risk for stroke is higher if you have OSA, and the development of hyperglycemia and the condition called the metabolic syndrome, obese, snoring, hyperglycemia, some with kidney disease and COPD. There are so many health conditions connected with OSA, and their primary pathophysiology is the intermittent hypoxia a person gets during sleep. This will give rise to all hypertension, coronary artery disease, etc. And they found out that treating OSA wipes out all of these conditions. So that's why they have really a high degree of association. No? When you reverse the OSA by CPAP, we'll talk about it later, they found out that treating OSA, you also treat these diseases. So these researchers have really linked OSA and the development of this hypertension, coronary artery disease, etc. So there is a growing interest in sleep and the appearance of these chronic conditions in patients. OSA will also have problems in other aspects like sexual intimacy. It has been shown on different studies that if you have intermittent hypoxia during your sleep because of OSA, you have a risk for erectile dysfunction. It's around 48 to 80%. And they also noticed that if you correct OSA, the ED will also improve. Sexual intimacy is also partly affected because of sleep-deprived partners. So if your partner is snoring so much, then you will have also a sleep deprivation, and it will affect your relationship. So how do we screen for OSA? So OSA is screened by using the Berlin questionnaire and the Stop-Bang questionnaire. Excessive sleepiness, we can screen it by using the Epworth Sleepiness Scale or ESS. Okay, so again, Berlin and Stop-Bang will predict OSA. These are questionnaires that will predict OSA. And Epworth will predict daytime sleepiness. Remember that daytime sleepiness is part of the triad of OSA. And all of these have Filipino versions. You can actually give this to your patient and it is validated. And it's very, very simple to answer. So let's take a look of what a Berlin questionnaire looks like. So it looks like this one. So it has 10 questions. Very easy. And this is the Berlin questionnaire Filipino version. Like in category 1, humihilik ka ba? I think everyone will understand that. Ang iyong paghilik ay mas malakas sa paghinga, kasing lakas sa pagsasalita, mas malakas sa pagsasalita, etc. So, gaano ka kadalas humilik? And so on. This questionnaire will predict if the patient has a really high risk for OSA, along with the physical findings, of course. And we have the Stop-Bang. Okay, Stop-Bang questionnaires was developed by an anesthesiologist from Vancouver, Canada. Usually, it is used for pre-op evaluation for surgery by anesthesiologists. But it has been validated to be useful to predict OSA, and this is way more simple than the 10-point questionnaire of Berlin. And it also has a Filipino version. You only actually answer 8 questions, and you have a scoring, and you have a scoring interpretation 0 to 2, 3 to 4, or more than 5. Okay, high risk, intermediate risk, low risk. So only 8 questions. So only 8 questions like snoring, tiredness, obstructive apnea, high blood pressure. You don't even have to ask that. You just get their blood pressure. BMI, you only ask for the weight and height, age, neck, You just measure the neck and gender. So this is very simple stop bang. You just only have to ask for snoring and tiredness, and of course observe apnea from the partners, but the rest you can already get it their data. Both the Berlin and the stop bang are very useful in predicting OSA. So how do we diagnose OSA? So the questionnaires will only predict or screen for OSA, but diagnosis of OSA is done using a polysomnogram or using portable monitors. What does a polysomnogram looks like? Okay, so polysomnography is actually what we call the sleep study, wherein a patient is being studied while being asleep. Many parameters like pulse oximetry, oxygen status, breathing status of the chest, EEG, and if you see the picture, this is from St. Luke's, Minnesota Hospital. Patients are being tested a lot of parameters while they're asleep. Okay. There are a lot of electrodes bedside, and so patients are left while they're asleep. So like this one, doctors will observe if the patient is restless or snoring or there is arousal from sleep. Okay, so that is the polysomnography. Portable monitors, on the other hand, are those contraptions in the body when you're sleeping, but you can bring that at home. You just sleep at home, and portable monitors will examine you while you're sleeping, and this will be recorded to a chip. Then when you wake up, bring the chip to the doctor, and the doctor will put that into the computer and read it. So again, usually PSG or polysomnogram is done in the hospital. They let you sleep in the hospital and observe you while you sleep. Portable monitors, on the other hand, you put it in yourself, you bring it at home, then you just surrender it the next day, and there will be parameters. Of course, polysomnography is still the gold standard, and it's more complete because it will read the brain waves, the patterns of your legs, the chest rise, and apnea, or any arousal from sleep, because a sleep technician will observe you throughout the night. While portable monitors, they just monitor a limited number of parameters of the polysomnography, but the advantage of it is you can actually sleep at your own home. So both of these look for apnea and hypopnea events. They record the apnea and hypopnea events. This is what we call the AHI, or the apnea hypopnea index. Both of these devices will record the number of apnea you have in an hour, and if you have 15 of this apnea and hypopnea in an hour, you have OSA. So what are the treatment options for OSA? Okay, we have the following options. First is the CPAP. CPAP stands for continuous positive airway pressure, and it looks something like this. You are being strapped to a sealed mask. Okay, it must be airtight sealed, and it is connected to a machine that pumps air into your airway, and this air has sufficient pressure to lift up the segment and relieve the obstruction so that you could breathe normally. And this is the primary treatment for OSA, CPAP. The use of CPAP reverses a lot of the OSA's conditions, especially if you already develop health conditions associated with OSA. They will reverse it. Okay, the disadvantage of CPAP is that every time you sleep, you have to hook yourself to a machine. Sleeping is with a machine, and sometimes some patients, they get uncomfortable sleeping with a mask on. Other options include weight reduction. As I told you earlier, if you are obese, you have a higher chances of OSA, and if you reverse that into a normal BMI, you have a lesser degree of OSA. In studies, a 10% weight loss can mean a 25 less OSA. What more if you have a 20% weight loss? It can potentially reverse OSA. Third is positional therapy. If you can remember, OSA usually manifests in the supine position, and the collapsible segment is more pronounced on the supine position. So there are some OSA patients, especially those mild OSA patients, gets relieved when sleeping on a lateral position. Some even have this contraption. You put it in your back so that it will prevent you from sleeping on the supine position. You just sleep on your side. Some even put tennis balls in their t-shirts so that when you go to the supine position, it will hurt and you go back to already on a lateral position. And take note that these patients, they may be a little uncomfortable at first, especially if they're really used to the supine position, but after a few months of using these contraptions, they will be already used to the side sleeping position. Oral appliances, usually these are contraptions made by a dentist. Oral contraptions look something like this one. You have like a contraption on the upper arch of your maxillary teeth and a contraption on the mandibular teeth. This will have a hinge wherein when you close your mouth, the jaw will be moved forward because of this metal that will direct it forward, and thus it will move the jaw forward, and also the tongue will move forward, and thus the airway is more open than before. So again, moving the jaw forward will widen the airway. And studies have shown that using the oral appliance improve OSA and daytime sleepiness. Surgery usually is employed especially when we want to increase the dimension of the upper airway. Improving the dimension of the upper airway will improve OSA and daytime sleepiness as well. Surgery will also decrease the pressure requirement of CPAP. Remember that CPAP, you put pressure to open the collapsible segment, okay? But if you have so much collapsible segment, like if you have big tonsils or big adenoids or a uvula that is so large, you will need a lot of pressure to keep it open. So if you do surgery on the tonsils, on the base of tongue, on the uvula, so the pressure requirement for your CPAP to open the airway should be decreased. And this will increase compliance of this patient to their CPAP. So these are the examples of surgery to relieve the upper airway. We have the tonsillectomy and the uvulo-palatopharyngoplasty or UPPP. Okay, uvulo, the uvula, the palate, and the pharynx. Plasty means repair. So here, this is a good example of both. You remove the tonsils, so there's no tonsils over here. And palatoplasty, the palate is being repaired. It is lifted upwards. You also lift the uvula up if you lift the soft palate up. Next is tongue reduction. Okay, so this is the tongue. Some people have excess tissue at the back of their tongue. If you reduce that, even on a small degree, you will increase the diameter of the airway. Okay, so this is what we call tongue reduction surgery. And another technique of moving the tongue forward is what we call the genoglossus advancement. So this is the genoglossus. The insertion of the genoglossus is pushed forward. So this is the bone. You place it more forward. You open it up, then place it a little bit forward. If you can see here, it is placed forward. If you place it forward, the tongue also moves forward. And we have the most complex surgery of all, the maxillomandibular advancement, wherein you do surgery on the mandible and the maxilla and place it forward so that you will bring also the tongue forward. Especially those with very, very small or receding chin. Okay, you project it forward so you will have a wider airway. Okay, let's talk about OSA in children. So in children, obstruction is usually caused by tonsil and adenoid hypertrophy. So this is again the adenoids. It is usually found at the back of the nasal cavity and the palatine tonsils. Okay, both of this will be enlarged in children, and when they sleep on the supine position, both of these will actually contribute to the obstruction during sleep. This is a growth curves of tonsils and adenoids in children. Take note that the adenoids reaches its maximum size around 3 years of age, and the tonsils around 6 years of age. This age group from 3 to around 6, they represent the children with the largest tonsil and adenoids. And these are the children who snores the most and have OSA. And take note that the adenoids usually involutes around 7 years of age and usually is not already seen in children 12 years old and above. And the tonsils usually also regress in size and usually not seen already in 15 years and above. OSA symptoms in children also differs from adults. Usually the symptoms, aside from excessive sleepiness, memory, and attention problem, they will have poor school performance. and they are noted to be more hyperactive, very, very hyperactive, and they also exhibit signs of enuresis or wetting in bed at night. And in children, surgery is the mainstay of treatment, usually through tonsillectomy and adenoidectomy. And this is curative for OSA in children. Not much of the CPAP or the oral appliance or those seen in the adults. You just have to remove the tonsils and adenoid because these are the one that contributes to the obstruction of the airway. So in summary, our sleep should be restful and restorative. An airway obstruction which leads to frequent awakening will affect restful sleep, and the lack of restful sleep will cause excessive sleepiness, which will also affect our daytime performance and a lot of chronic diseases. So, awareness and treatment of obstructive sleep apnea in our patients will help us restore their good sleep. And this is the end of my lecture. If you have any questions, feel free to email me or to visit my website or my FB. Thank you.